Did you say yay?
All right, good afternoon. Welcome back, everyone, to the Multnomah County Board of Commissioners, now 8th budget work session. Audience members, I want to start by asking you to please silence your electronic devices. For those presenting today, please turn your mic on when you begin speaking so the green light is showing, and off when you've completed your remarks so that the red light is showing. And then for all presenters, please state your name for the record before speaking or responding to questions. And we are back with our lovely health department. Our first briefing this afternoon is on the integrated clinical services. And I will turn it over to Rachel Banks.
Thank you, Chair. Good afternoon, Commissioner Moyer, Commissioner Singleton, Commissioner Brim Edwards somewhere, and Commissioner Jones-Dixon. It's great to be back here. Hopefully you all got some great lunch and refreshments. Oh, did you see the, yeah, we had Vietnamese food. There's a half a sandwich upstairs, I'm happy to share. For the record, my name is Rachel Banks. I get to be your health department director, and I am here with this group of fabulous folks from our integrated clinical services who run our community health centers that will be introducing themselves and walking you through a presentation of all the fabulous things that we do and their great thinking that they've been doing, preparing for some of the changes that are coming down the pike. With that, I'll hand it over. Donarud.
Yeah, thank you. Good afternoon, Chair. Good afternoon, Commissioners. For the record, my name is Anirudh, he, him pronouns, and I have the honor and privilege of serving as the Integrated Clinical Services Interim Executive Director. With me today, I have our Acting Board Chair, Darrell Wade, along with my wonderful colleagues, Adrian Daniels, who's our Policy and Strategy Director, and Hassan Bader, who is our Chief Financial Officer, and when we, and I will just pass it to all of them to introduce themselves, and yeah.
Good afternoon, Chair and Commissioners. My name is Darrell Wade. I am the Acting Chair and Consumer Member of the North Portland Clinic and Community Health Center Board. We're a co-applicant partnership with the Board of County Commissioners. Our board manages the provisions of comprehensive primary care, integrated behavioral health, dental pharmacy, and wraparound services. The CHCB is a federally mandated governing body with a patient majority. As a patient of the health center myself, I am honored to serve the board's skilled community and consumer members. The Community Health Center Board collaborated with the senior leadership team and interim director to perform an extensive strategic priority assessment. This planning phase commenced following the board's approval of the fiscal year 2026 through 2028 strategic plan in September 2025. Beginning in November 2025, the CHCB focused on evaluating capital needs, visit and financial forecasts, and potential consequences of federal legislative changes. The CHCB follows HRSA governance regulations by approving its entire budget rather than endorsing individual packages for the county. Once the CHCB approves its budget, which we did at our April CHCB meeting, it is integrated into the broader health department and county budget and follows the formal county budget approval process. The board establishes specific objectives for the health center for the next fiscal year through several strategic dialogues. Details regarding these identified priorities were presented in the next slide. Representing the patients of the health center, our mission is to ensure high quality, all-inclusive care remains accessible to our community. The strategic investments outlined in the fiscal year 2027 budget for the health center directly supports this objective. In collaboration with the executive director, the board has prioritized enhancing patient access by creating additional patient-facing positions throughout our clinics. For the upcoming fiscal year, the CHCB has established 3 primary directives for the health center team. Maintain and improve access to clinical care amid significant changes at the federal level. Ensure diversified appointment options such as telemedicine and in-person visits. Strengthen patient engagement support systems, focusing on social needs and insurance assistance. To navigate upcoming Medicaid challenges, we are also making significant technological investments. The electronic health record transformation project is a key strategic priority of the CHCB. There have been challenges in moving this project forward. We look forward to seeing this budget and strategic investment of the CHCB move into the execution phase. Honorable.
Thank you, Darrell. All right, in the upcoming slides, I hope to talk about the story of our community health center. This slide is a representative of how our budget changed year over year. Very small budgetary change, and while our operating budget has gone up a little bit, we can also see that our FTE equivalent has gone down a bit, and Trista mentioned this in her presentation this morning. Accounting inflation, this is actually a reduction while we see the numbers going up. In some of the upcoming slides, I will go deeper into how the health center budget truly delivers for our communities and the story of our budget. The FTE reduction that you're seeing here is largely from the field administrative positions. And as Darrell mentioned, guided by the CHCB's position priorities, the health center made intentional investments into clinical programming that allows us to care for more community members that walk through our doors or through our mobile van. We're maintaining those services. And then our student health centers, our dental program, our integrated behavioral health programming. And one key point that I want to mention here is that while we are preparing for all of the headwinds through the HR1 federal changes, one of the intentional ways that we are taking to approach some of those challenges is by investing back into the clinical areas that allow us to the Oregon's unique CCO model allows us for patient assignment. So there's, at any given time, there's a gap between how many patients or clients that are assigned to us to those that are engaged with us. That always gives us a target to aim for that brings in the additional revenue. So that is where investments into the clinical programming really plays a factor into us being financially solvent.
A question that you asked earlier, Commissioner Moyer, and that Hassan and I were talking about, just to answer part of that. So what this budget does is, to your question about are we adding more Medicaid eligible services, yes, and none of the reductions in this area that you see are for Medicaid billable pieces.
Yeah, thank you. In the next slide, as I think of our health center's budget itself, the phrase social enterprise comes to my mind. The health center's vision and purpose call upon us to ensure that members of our community are receiving reliable, high quality, inclusive, and comprehensive health care. And while doing so, we are eliminating the health disparities and advancing health equity through integrated approaches and providing care that is culturally, that is collaborative, culturally congruent, and comprehensive. And now, how do we do that? We do that by centering the experience. So one of the things that we did at the onset of our budgetary process was we have formulated a set of guiding principles in support of the health department's equity framework. One of the core values that we prepared our budget was by centering the experiences of vulnerable populations and how the budget impacts them. So that is where holding direct clinical service physicians harmless was one of the approaches. The second thing was to add more provider positions that allow us to provide more access. So that was one of our guiding principles. And then the second thing is how staff, they are part of this process. So we do that by ensuring that we're investing in the areas that we received extremely positive feedback from the staff about, which is our workforce development programs. And then finally, by tackling the changes or challenges of HR1 head-on through process improvements and investment into technology. In addition, I will go into each of these sections here. In primary care, the budget delivers by increasing clinical teams to increase patient care access. Our strategy here, as I mentioned, is to fill that gap between who's assigned to us and who's engaged with us, and then bringing about the revenue that would have otherwise been left on the table. Additionally, by seeing patients, new patients, those that are assigned to us from the CCOs, this also allows us to invest into the other areas of programming within the health center, like our community health workers, our population health teams, who help our community health workers who help clients navigate many different social drivers of health, our population health teams who help with reducing emergency department utilization, with chronic disease management, and more. And Commissioner, to borrow your trampoline analogy, Valdez used it at the presentation this morning. I was hoping I'll be the first one, but no. So the health centers continued investments into the highly impactful and effective advanced practice clinician fellowship program is how we provide a launch pad for members of our community and building that workforce of the future. And in dental, what we are doing is we are maintaining the programming at the current service level. The dental team has a multi-year roadmap that they are looking at, where they're looking at operational improvements and our fiscal year 27 investments maintain support for that roadmap. For our dental program, they're also investing into workforce programming for certain auxiliary positions within the dental practice that also help support building the workforce of the future. And pharmacy is looking at its own operational improvements of their own, including looking at the clinical pharmacist program and how they play a major role in the care teams within our clinics, optimization of their appointment schedules, and more. What that does is it allows, when we have an optimal program, it will allow us to consider any other future workforce or residency programs that could be part of the pharmacy programs. And then finally, this budget is making strategic investments into the evaluation projects, be it the behavioral health service needs evaluation, as Darrell mentioned, some of the technology investments, but then also the Mid-County Capital Project, and also we'll work really closely with this commission about the Walnut Park project itself. And in the next slide, so as I was walking in, I was having a hallway conversation with Laurie Dola-Scott from Corrections Health, and she reminded me the power of gratitude, and that is what this slide really is talking about. This is an area that I am incredibly proud of. At the health center, we are nurturing that culture of recognition and celebration. This also gives me that reminder that we're part of something bigger than ourselves, and our strength truly comes from that collective contributions and collaborations. So in the last year, as you all know, there have been significant shifts in the national policy on healthcare, and our staff have risen to that challenge on how we stand up and respond to those. And these are some of the pictures here of our staff. Our health center staff and programs receive national recognitions for extraordinary performance and services. We are proud of what we have accomplished, but we also intend to continue on this promise of excellence as part of this 2027 budget. I want to give a couple of quick shout outs. Aaron Baeza received the Geiger Gibson Award. He is one of the 14 across the nation to receive this Emerging Leader Award at the National Association of Community Health Centers. And the work that he did was he shared his experience of being a farm worker as a child, to picking cherries, to really working at our health center, getting into the healthcare administration, and helping address those very same social drivers of health that he experienced as a child. He helped design some of our referral centralization program, in addition to some other programming that allows our clients to receive transportation assistance and other services. And then a couple of others. Our very own Adrian Daniels was recognized as the Community Health Center Policy Champion at the Oregon Primary Care Association Award. Our Norma Santiago Hernandez, she was recognized, she's not pictured here, but she was recognized for compassion in practice, for developing the workforce development pathway. And I think one final thing that I will say about this is that sometimes work, as we see in the surveys, others can feel draining, and that is where just being among so many cool people and that do such cool work is just that reminder of all the great things that happen at the health center and at the county. In the next slide, this is something that we chose to highlight out of the 3 different KPI statements that we have as part of our budget. I've talked about new investments into primary care access, maintained investment in our dental, student health, pharmacy services. This slide really just talks about what we are projecting with respect to the new patient access that I previously referred to. And as you see, year over year, we have been making progress in providing new access to services across our system. So we hope to do that continually, including in this fiscal year 2027 budget. With that, I will pass it to Adrian.
What's the number of, do you have the number of unique patient visits?
Yeah, so in calendar year 2025, we saw 60,205 unique patients.
Thank you.
Adrian.
In slide 8, when you talk about integrated behavioral health services, from the FQHC standpoint, what services do you deliver?
Do you want to take that?
Thank you for the question, Commissioner Moyer. We can briefly provide an overview today. And
Can you please state your name for the record?
I am so sorry. For the record, my name is Adrian Daniels. I'm the Strategy and Policy Director for the Community Health Center. Thank you for the question. So when we talk about integrated behavioral health services at the FQHC, it's a generic term that may not be used universally or consistently across all health centers in the United States. However, those are services that we provide as part of our primary care medical home model that can range from the peer mental health associate all the way up to licensed clinical social worker and psychiatric nurse practitioners who can provide same-day or short-term interventions for common mental health and behavioral health disorders, ranging anywhere from anxiety to early stages of psychosis. But we'd be happy to get you a summary of a more detailed overview of what those services look like.
That'd be great.
Adrian, it truly is yours now.
Next slide, please. Okay, Unard got the lovely job of telling you what we're excited about next year. I get to talk about things that are challenging, but we're going to rise to the challenge with the rest of the county and addressing these areas. There's 4 big things that we've really been thinking about with our board in the upcoming year and with the rest of the county. And so I know the commissioners are very interested in how we continue to support Multnomah County across lots of different federal changes. Number one on our list of concerns certainly is how HR 1 is going to impact matching funds for the state of Oregon and other states who did massive expansions of the Medicaid health program. In Oregon, it's estimated that we're going to see a loss of about $2 billion per year across the entire state in Medicaid programs. The Oregon Health Authority has already announced that they will change reimbursement models for their Medicaid lookalike programs known as HOP. And how they plan to assign patients. And so we're already starting to see some of these changes take place, even though we have not actually entered that official January 1 start date for most eligibility changes in primary care. Certainly, we're also looking at the loss of the provider tax in upcoming years. We don't anticipate that will have a direct impact today. However, we do see the indirect sort of shuffling of funding happening at the state level, where the state has already made decisions about shifting quality payments away from primary care so that they can invest in other specialty services at this time. So we're continuing to work with our government relations team and other parts of our state advocacy coalitions to really highlight the risks of when you continue to defund primary care and defund public health systems, what that means for the larger healthcare environment years down the road. On the lower half of the slide, there are two other things that we're really watching this year. The first is the administrative challenge of HR 1, where we know we're going to be looking at increased burden on both our staff and patients just to stay enrolled for programs that we know they're still eligible for. We are awaiting final guidelines from CMS. The rumor is they're supposed to be released in the next 2 weeks, but technically they have until June. So we are still playing a waiting game, but we're talking with the Oregon Health Authority on a regular basis about what we believe will help reduce burden for patients. So things like how can we make it easier for patients to stay enrolled if they have a medical condition that would keep them exempt from work requirements, for example. How can we make it so they don't have to attest every 6 months? We could just pull that straight from medical records or historical records of insurance. Other things like place of service, we're also encouraging the state to consider, where if we know, so for example, someone was in the emergency room or the hospital, we could use that as a way to prove eligibility for ongoing Medicaid services. On our pharmacy side, we participate in the 340B program, and we've seen a lot of activity at the national level this year where drug manufacturers have challenged the validity of that program or how it has been able to be expanded to community health centers. For our community health center, the 340B program lets us purchase drugs at very, very low cost and then distribute them to patients at very, very low cost as well. So one common example that you hear about in the news is insulin. There was an executive order actually talking about how insulin prices need to go down. We're able to provide insulin to patients at between $10 to $15, which is very, very low cost if you've ever had to purchase insulin directly. But it's thanks to the 340B program. And so we're continuing to work on how we can make sure we can participate in that without new costs to the system, which would limit patient care. Next slide, please. I mentioned before what we're really watching with HR 1. So there's really some concerning rules that CMS is putting out about how they can prove 80 hours of work requirements. That has yet to be defined. We've actually seen some states from I would say, like, Republican states actually start to advocate to CMS that they walk back this requirement because they themselves are having trouble proving the 80 hours of work when they've rolled it out early. We're actually hoping to learn from those states' experiences. So Arkansas, Georgia are two states that have done this in the past, and their Medicaid directors have been very forthcoming about what works and what doesn't. That being said, we still have to wait for CMS to release their own final guidelines in June before the state can make decisions that then trickle down to providers about how we will have to support patients through the Medicaid eligibility process. So we're still in a bit of a waiting game here. And the next slide, sorry. So that leads us to what are we doing about this? There's two things we want to really focus on. The first really speaks to how do we make it easy for people to still come in and get care, how to access appointments within a primary care system. There are certain things that we've been testing out this year, which we're expecting to expand in the next year, even with HR1 changes. So for example, we have been very successful with what we call a nurse triage team for post-hospitalization follow-up and scheduling. So if someone has been to the emergency room or to the hospital for certain treatments, we're able to get in contact with those patients directly and encourage them to come back into primary care, which can be a great indicator for long-term success as opposed to readmission back into the emergency department. We have also begun to evaluate the impact of changing our what we call a self-pay schedule. So for patients that don't have insurance, we're able to offer them services at very, very low cost based on their income and family size. As we are anticipating more people will lose insurance in the next year, we want to reevaluate that scale to make sure we're not putting additional burdens on patients who might all of a sudden be facing new fees just to access healthcare. If we go to the next slide, I'm going to talk a little bit about technology. So there's a couple things that we're also excited to see roll out this year, specifically with our partners at OCHIN. There's 2 specific tools that we will be testing this summer and fall. The first is known as a financial assistance module, and the second is known as a payer platform. These are tools that you can use to help a patient understand when their insurance will expire or how much their services might cost them in the future. And by really piloting these with our eligibility teams, we're really hoping to streamline our workflows and refine them so that we are fully prepared when new work requirements hit to advise patients on what their options are to stay insured or if there are other insurance programs that they might be eligible for so that they can continue to get health care at very, very low cost or no cost to them. We're also continuing to meet with our CCO partners about how we can message in a collaborative manner so that they're not hearing different things from their insurance organization compared to their primary care physicians about who they need to submit paperwork to and what programs they remain eligible for. We're also looking at same-day outreach to patients. For example, our dental program, Honored Mention, has been really focused on how does it increase access this next year. No-shows are really high for new dental patients, and so our team has been piloting a new way of getting those patients to confirm that they're coming in and sending reminder messages so we can really hyper-focus on where that highest need is. And these are some of the ways that we're hoping we can really decrease the impact of some of those major federal policy changes in the next upcoming 6 months. I believe I'm going to pass it to my friend Hassan.
Thank you, Adrian.
Hassan, I just want to make one point before we go to you.
Okay.
So Commissioner Moyer, you asked in a previous presentation around the impacts to the LGBTQIA2A+ community with any of the budget changes. Because of the fact that we are preserving our access in addition to increasing access, we hope that our budget does not negatively impact any of our current clients or those that are coming to seek services. And then one other additional point that I want to make around this is one of the Health Center Board's priorities are to the community partnerships, and we are in conversation with some organizations to see how we could potentially take primary care access to their to their place of service. Don't want to name drop or any of those in this moment, but that is something that's in our radar.
Have we thought about how we will navigate gender affirming care when Medicaid no longer covers it?
Yes, it's not something that we've wanted to have to think about for quite some time, but one of the things that we're very lucky to have here in Oregon is a strong primary care association, which has contracted with several different advisory groups about that exact question. Some of the things we've been able to do already as a protective factor is just look at how our Direct 330 funds are being spent on certain positions. We're able to move those around fairly easily, and we've done that proactively to make sure that we're protecting providers who are really very, very dedicated to serving that community, just in case there's ever a complaint that comes our way. There's a lot of historical precedent about federal funding being restricted at the grant level, but not necessarily at the Medicaid level. We're certainly watching the Supreme Court cases around gender-affirming care in minors and states' rights to restrict that really, really closely. One thing that gives me a ton of hope is that the Oregon Health Authority has protected those services as part of our Constitution, and so it would not surprise me if Oregon challenges those rules quickly, and we can rely on the state to provide alternative avenues of funding so we can continue to provide those services.
Yes, my name is Hassan Bader, and I am the newly promoted CFO for the Integrated Clinical Services, or the Health Center. And thank you. We have some position or FTE reductions in ICS, and the reductions are currently, the reductions were focused on currently vacant positions, and we were able to limit the impact to staff, and employees or positions impacted are administrative and non-client facing positions, and the decisions were made based on operational needs. Next one, please. The total reduced FTEs in ICS about 19.1 FTE. Next one, please. The Community Health Center capital priorities. We have, under the direction of the Community Health Center Board, and we have a strategic plan that identifies support for investing in technology to assist patients with accessing care and identifying improvements. And I think Anirudh and Adrian mentioned some examples about that, but the focus here is we are continuing investment. We are continuing investments from fiscal year 26, making sure that we are the budget level is maintained for fiscal year 27 to modernize OCHEN EPIC EHR, or electronic health records. And we have been doing studies regarding Mid-County Health Center, where we provide primary care, dental, and pharmacy services. And the evaluation about long-term needs of this location, the initial forecasting for repair or replacement options. And we have engaged in discussions with facilities and with the county CFO. The other priority is Walnut Park, where we have Northeast Primary Care Health Center and dental and pharmacy services as well. And we participate in quarterly planning regarding investment options and future services. We are in the middle of remodeling Rockwood Clinic, where we also provide primary care, dental, and pharmacy services. And this is a partnership with DCA, and we have funds from federal sources and county sources. Anything you want to add, Anirudh? Great.
Okay. I think we're back to some more fun legislative updates.
I have a question. Do you have a map of where all our clinics are?
Yes, we do.
And do you have any in District 1? Old
Yes.
Town? Is that where?
So we have our Health Services Center, which is in the Gladys McCoy building. And we also have our Billy Odegaard Dental Clinic. In addition to that, our mobile van provides services in the downtown corridor in some specific locations. Yeah. Cleveland.
Cleveland.
It's, the border is really, really close on that between District 3 and District 4.
But nothing in Southwest? Yet?
Well, downtown is Southwest.
Depends where in Southwest. I mean, where downtown, but okay.
You are correct.
All right, I think we're just closing out our formal presentation with some highlights from the Oregon legislative session. We worked with the Health Department and Government Relations this February and March to really review changes at the state level impacting primary care services, and I want to highlight two of them for the board this afternoon. The first one, Senate Bill 1570, really talks about where federal immigration authorities are permitted to operate in healthcare organizations or locations. So this was referred to as healthcare without fear during the legislative session, and we supported this bill, and it really strengthens what the county had already put in place and what our health center had already made part of our own internal policies by just making it really clear that waiting rooms are not public spaces for anyone to come and hang out in. These are considered part of someone's private right to have a conversation with their provider. It also strengthened what information is considered personal health information. And so the idea that you might have a conversation with your provider about where your family is from, what your childhood was like growing up, that is not subject to just sharing. And we're very, very happy that that has now been codified as part of protected health information under the Oregon statutes. We're rolling out updated trainings and reminders to our staff this month and over the summer, just encouraging them to continue to follow what our standard release of information process is. But we're continuing to follow how this continues to impact members of our community, especially in hospital settings. The second bill up here, House Bill 4088, also continuing to strengthen what we consider critical primary care services in Oregon related to reproductive health and gender-affirming care. While Oregon has some really strong constitutional protections for this type of care already, 4088 went a little further in actually speaking about provider protections, given the diversity of state laws in the United States about how providers or people who assist in seeking healthcare services might be prosecuted. The state went ahead and added additional layers of protection to providers with an Oregon license who work for Oregon health agencies, that they are also protected from outside lawsuits and litigation. So while this does not necessarily change how we provide health care, we've supported this bill from the perspective of an employer and as an organization because we want to make sure our providers can feel safe in delivering high quality care services. I believe that might be our final slide.
All right, open to questions.
So I just want to come back to the Medicaid recertification, the constant proving that you're still poor. What is the conversation? Are there technological solutions here? 6 months is insane. For anybody who has done this work in the field, this is going to be really a huge burden on the people who need the service, but also on staff. And so I'm just curious where we're at around any technological solutions, what conversations are happening, if you're hearing things from other states that might be looking at these opportunities. And then also, is there an ask we should have around, remember when we had Medicaid expansion and we had assisters everywhere in the community helping folks get enrolled? What is some opportunity there? Is there something we should be thinking about for state advocacy around this? And it may not be something you can get into all the places you want to today, but that's part of what I want to start digging at a little bit.
Yeah, from our perspective, a few different approaches or strategies is absolutely that advocacy with the Oregon Health Authority and helping set some of those medical frailty definitions. So that's one aspect of the work that we are doing with our primary care association. And then as far as the health center operations itself, we are absolutely looking at technology that is already in progress to the applications or the modules within Epic that we have already implemented. We are looking to see how we can partner with our coordinated care organizations to see what information can be exchanged back and forth to do that validation of eligibility. And then we are also looking at some additional, in one of the slides, slide number 12, Adrian talked about Epic's financial assistance module. This is one of the things our EHR vendor is talking about, how that could help alleviate some of the burden on us. And then the last piece in this is over the last year, our registration and eligibility teams have done some process improvements, and I believe as a result of those process improvements, it will set us up for success, either through the new call center platform that they went on or any process improvements that they have with respect to how many clients that they serve, and just that data-driven processes will also set us up for success as we look at the 60,205 clients and making sure that they stay enrolled or more.
I would just add some of the conversations that we're having at the state level include, Honoree mentioned with OHA and as it relates to some of the assisters and just what the rules are, and then also with our coordinated care organizations as they're grappling with the same questions about how can their technology be better. They're getting videos and stuff out right now in multiple different languages, and then also looking at how to shift some of the resources to help people with that administrative burden, to help individuals with the administrative burden, but also I think some of the asks for the state are around decreasing the administrative burden in other ways so that we can use some of those resources that might have been doing reporting or different things to them and focus on things like assisters for like client level work.
Thank you. I don't want to say that's awesome because the whole thing is not awesome, but I appreciate what you all are doing and digging into. I will say, I think that we have to figure out how to help educate the hundreds of case managers we have out in this community. I was running a day center at the time that we had this expansion, and I had assisters, 3 of them in there every day for weeks, and we still didn't get to everybody. And this was out in the east side where it was a little bit less traffic. So I just think that there's folks who may not be coming through the clinic as regularly that are connected with services in some way. And if those case managers don't know how to help their folks get to the right people to keep the certification, we're gonna miss people. And so I don't have a solution to that. We can totally talk more about it, but I just want to make sure that folks aren't falling through the cracks because we didn't kind of run trap lines in a couple of different places.
It doesn't seem like there's any other questions for you, so we just appreciate the time. I know.
One day we got done early.
I know.
I'd like to say that for the record.
I would also like to say, this is we gave so much time to Health Department knowing that you always run, and so that's why it's finishing.
I also reserve to right to ask any question about any division as it comes up to me through your many, many more days of presentations.
I do have questions about what projections, which I do understand if we simply can't yet, but I'm trying to kind of wrap my head around what kind of degree we are expecting to be potentially providing uncompensated care and how we're thinking about that, just knowing that that really starts in 27. So I don't know what you are able to project and what that looks like of the percentage of insured people we're serving today and what we think is likely
Yeah, absolutely. So that was one of the things that we did as a senior leadership team starting in October of last year. Historically, we've had about 14% uninsured in our system. And right now it's about anywhere from 5 to 8%. So we are expecting that we could potentially go back to that 14% uninsured and give or take 5 to 10% increase in uninsured clients that will come through our system. So that is how our fiscal year 2027 budget projections have been made.
Okay, thank you.
Okay, thank you all so very much. It's great to have you here. Thank you so much. And if there's follow-up questions, we'll share, but it doesn't seem like that for right now. All right, we'll see you tomorrow for behavioral health.
Thank you for stepping into
Yeah.
chair role, too. I know you were here last year, but I know it's a lot more, so thank you.
All right, so now we have time. So we had set aside some time for follow-up if there were any public safety questions and follow-ups. We had some in writing, but didn't see a need. There was no need to bring folks back. But we did run out of time yesterday for the Homeless Services Department, so I'm going to invite them back up.
I didn't bring that down either.
Well, hopefully your staff is in the room so that you can bring down that. So we're going to have our Homeless Services Department. We're going to take a 10-minute recess so people can get their materials, and then we will start at 2 p.m. We are in recess. right, and we are back to business with our Homeless Services Department, who has so graciously returned to follow up on yesterday's presentation. So we will delve right in to supportive housing services, I believe. Supportive housing.
So afternoon, Chair and Commissioners. My name, All right, Kanoy Eggleston. My pronouns are she and hers, and I'm the Program Director for HSD. I'm going to walk us through the next two divisions. I'll start with supportive housing. So supportive housing in this division can take the form of both permanent supportive housing and recovery-oriented transitional housing. So as a reminder, PSH, or permanent supportive housing, is a type of deeply affordable permanent housing that provides support services to individuals with significant disabilities. PSH is designed for those who have experience or are at risk of long-term or cyclical homelessness and have extremely low income. It combines long-term rent assistance with ongoing wraparound support services. PSH can be provided in site-based buildings, so what that means, it's a single building that has dedicated PSH units and is often referred to as project-based. PSH can also show up scattered across multiple sites and follows the client and is referred to as tenant-based. So as we move through this division, we start with Corey's story as a way to ground and remind us of the tangible impact supportive housing programs have. One of the key features of site-based PSH is service integration, which ensures services are on-site or easily accessible, often including 24/7 staffing and specialized team-based support services. So Corey is a resident at Meridian Gardens, which is a site-based PSH community operated by Central City Concern and offers recovery-focused services for its residents. Corey notes how these site-based services have been a game changer and shares, "I have a family surrounding me, my daughter is back in my life, and I have a good group of people here." Next slide. So limited resources has been a challenge across all of our divisions, and our response has continued to be guided by the department's policy goals. And in order to keep people housed and prioritize housing placement, HSD minimized reductions in this division. We have continued to prioritize the expansion of PSH units, and next year's budget will bring us to 87% of the 10-year SHS local implementation goal of creating at least 2,235 PSH units in our community. Next slide. This slide highlights the division's operating budget and staffing across this year and next fiscal year. There is a $71 million investment in supportive housing programming next fiscal year. This increase includes that continued expansion of PSH, with 1,952 units online at the end of next fiscal year. Next slide. So this map illustrates HSD-funded PSH projects that are in operation and currently in development across the entire county. This map represents only only project-based PSH. For context, about 55% of PSH units supported by our department are project-based, and the remaining 45% are tenant-based. Next slide.
Can you explain the difference?
Between project-based and tenant-based? Yeah. So just earlier I had mentioned project-based or site-based. Site-based, it means that it's in a single building and there's dedicated PSH units, and that's often either you can say site-based or project-based. And then you have the other option, which is scattered across multiple sites. That's when the rental subsidy will follow the client, and that's often referred to as tenant-based. All right, so this slide shows people newly housed. I think that's an orange color, and people sustained in housing, that darker color, through supportive housing strategies by fiscal year. To note, the estimated number of sustained households for fiscal year 26 are likely low, and that'll be adjusted. Projecting that number is complicated when you have large fluctuations on the number housed in previous years, and we believe that actual number is closer to about 3,200, which matches the data we are seeing on our dashboard. So one of the key components, as I mentioned, of supportive housing programs is that longer-term commitment of wraparound services and rental subsidy. So it's no surprise that one of the main focuses of this division is that continued investment in sustaining households in this type of permanent housing strategy. Next slide. One of the goals of this division is to ensure we are serving Black, Indigenous, and people of color at or above the rates they are experiencing homelessness. This slide highlights where we are achieving that goal through our supportive housing strategies. Over the last year, HSD has made progress in this area by continuing to prioritize culturally specific PSH expansion. Next slide. So this slide shows retention data in supportive housing programs at 12 months. Supportive housing programs continue to succeed in targets for retention, surpassing national standards. Next slide. And this slide is retention data at 24 months, and what we see is that continued high retention rate in PSH programs. And that's the end of this division. So next slide. Yeah, we can pause. Oh, yes, no, questions, of course, for the group, yeah.
How else is this going to take 8 days? Fair, fair. So I'm interested in your engagement with the Medicaid consultants that the county hired related to looking at permanent supported housing. Are you able to talk, or do we need, maybe this isn't the right panel to ask, about what they were able to advise the county on as it related to potential for getting Medicaid match?
So I will, Justin is like the expert here, but we are working with them to do that analysis. I know they have drafts coming. I don't think we have an answer yet on exactly where we're at on that. But it is in flux and it's in process.
What is?
Justin missed the question.
Oh.
Didn't miss the question.
Okay, so the question was, knowing that we had our Medicaid consultants look at permanent supported housing, what have they advised the county as far as the potential for Medicaid match in permanent supported housing?
Hi, everybody. Justin Black, he, him pronouns, Deputy COO here at Multnomah County. So we don't have final recommendations yet. What we are learning in our first drafts of the recommendations is that there is not, frankly, an easy silver bullet in this, that the level of complication and approvals that will need to happen are going to be laborious and take some time and continued work. What we're working on right now is getting the consultants to finalize those recommendations and prioritize which ones we should pursue first. I don't have enough on the permanent supportive housing yet to give like a good answer of like, this is the thing we should do in the next 6 months.
I just want to jump in and say, and I can share these with you, but one of the budget notes that I introduced yesterday talks about looking at the fidelity scale of PSH. And I think that would be helpful for the consultants to look at, because there are things there that I think we maybe aren't doing, that we should be doing, that are where some of the billable services come in.
Yeah, please share. And we've also been meeting with providers, and they've been meeting with providers to talk through, as providers have also looked at trying to do this, like Central City is the prime example of trying to how they can match it with their FQHC, and really the struggles they've run into, they haven't gotten it to a place where it's generating enough revenue to have meaningful impact, if at all. I mean, it's a slog. That's the biggest lesson we've learned in all of this work, frankly, is the slog that it will require, and getting to that question of, is the work actually going to cost less than the money that it will bring in? And the cost benefit on this is tough.
Yeah, I definitely, and we can for sure keep talking about it, and I didn't mean to take over your time, but other places are doing it, so we may need to take a look nationally and see why it's been so successful elsewhere. And a lot of it is they set it up on the front end of the program model, and we're trying to now bring it in on the back end. So I understand it might be complicated, but clearly the bang's worth the buck in other places, so I want us to keep working on it for sure.
And I think my nervousness on timeline, and I kind of flagged this when the governor floating this idea that the state was going to seek a waiver, that they had identified the wrong waiver, but that probably the best waiver in Oregon is the 1915I, which does not require institutional level of care assessment to access But Oregon is already starting our renewal process, and that is actually due in December, and they've had their first meeting. Their next meeting's May 19th. So I get really nervous. I don't want to miss this window if this is the best window. But I also think it's not just a Multnomah County ask. I think it's a full SHS ask, and I think it is really worth talking to our partners about making a hard ask of the state, because they are the only ones who can change or amend a Medicaid waiver. So I know that we're still like in the weeds and the timing's not perfect, but I don't want to lose this because it does have real potential. And I think, one of the things that I like about using long-term care waivers versus OHP is it's such a stretch to make a medical connection, but long-term care isn't medical by definition. And it will do things like employment services, retention services, like the list of things that a long-term care waiver could pay for is a better match to what we're doing. For me, I don't understand why the state is not proactively trying to partner. That's a different issue, but I really, I don't want to lose this because I'm really worried about timing. And that's not our fault, it's just how it happens to align with what the state is working on.
And I just to reinforce kind of what you're saying, so one of the findings of the consultants really was like the 1915C was the wrong mechanism to use and really refocused us back into the work we're already doing on the I plan. So, yeah.
Justin, all right.
I'm curious why are we decreasing retention rate targets?
This is in the rapid rehousing section too. So we are.
I know.
Yes. So this has to do with standardizing everything that's in our contracts, then rolls up to our program offers, then rolls up to our budget. So our contracted rates that we ask our providers is that 80%, and so that's why you see the 80% is the target. We routinely outperform that target, but that's it's building up from contracts out to our goals.
Thank you.
And it's the ATRAP goal, I should also say.
Yeah, 80%. I think you said there's a certain number of PSH units in the pipeline, and I just missed that number. Could you say that again?
There are going to be, I said it's 200. And so remember last fiscal year, we're going to start it in this quarter, and then it'll fully be online into next year. So at the end of the year, we're projecting 1,952.
Okay, thank you. And then on our project base, are they primarily the partnerships we've done with the Housing Bureau? And so the site-based are a part of affordable housing projects. So are we buying down rents at the 60% level?
I know in some of the newer expansion, that 200, there's a couple affordable housing properties that we're doing that with. And not all of our 1952 will be fully from those types of situations, essentially. Yeah. So a lot of them, most of the previous ones with the bond and everything, but when you look at expansion in the 200, we have, I think it's 2, but we can follow up on which units, or which projects those are, and how many units those actually mean out of the 200. Yeah.
Thank you. And part of what I've been asking about affordable units in the pipeline of the Housing Bureau folks, and the numbers are only 784 at 0 to 30. So as much as we can actually address that 31 to 60, where we know we've got vacancies, but it's also the biggest number that are going to be developed in the near future. So there's just continues to be that mismatch. I also know, because I gave everybody a hard time about how tenant-based vouchers have a higher retention rate, so I understand why there's a split. So I appreciate that we also want to keep that flexibility. I think that was my last supportive housing question. Let me double check. Yep, thank you.
Any other questions for supportive housing?
Okay, I got a quick one after you.
No, I was just going to move
Oh,
them
okay.
on, but please go ahead.
Oh, no. What is our, I'm kidding. What is our prioritization criteria? I mean, I know that's a complicated question, but, who do we identify as being appropriate for permit-supported housing? And is that just a wait list? Is it weighted by need? How do we determine that?
So when everyone will complete a missed assessment, that'll identify, are you eligible for PSH? Then you have a priority pool, and the way in which the priority pool is organized is it depends on what units are going to come online in the future. So it's not just around your score or the assessment, it's also ensuring what are the projects that are going to come online so we can actually match a person to a unit. And, I don't know if Anna, you want to add anything? Okay.
Thank you, guys.
The next division, you all. So I'm going to move us on to the System Support Access and Coordination Division. So this division is responsible for providing multiple types of support to ensure the effective delivery of services and promote equity-focused practices in addressing homelessness. Programs in this division ensure that the regional network of homeless services operates efficiently, uses accurate data, and prioritizes racial equity. Next slide, please. So in a resource-constrained environment, it has made system support more difficult and challenges our reserves. In response to this challenge, we have focused on our efforts on regional coordination and partnerships to align goals and be efficient and effective with resources. A couple examples of this are through our cross-sector case conferencing, where we are fostering cross-system collaboration between homeless service providers, HealthShare, other health system partners, and Multnomah County Services. And then another example is just through our tri-county coordination and regional investments that are related to health systems alignment, as we've just talked about, landlord recruitment and retention, technical assistance, and training, just to name a few. Next slide. So as previously mentioned, programs in this division support the system of homeless services. So that's from data analysis and reporting, evaluation and planning, community engagement, regional planning, and system-wide training and TA, all to ensure equitable and effective services for individuals experiencing homelessness. Next slide. So this slide highlights the division's operating budget and staffing across this year and next fiscal year. The significant change in this division is the 6 FTE reduction. As core services are prioritized, this means taking commensurate cuts across all divisions. So internal operational reductions occurred as the department's priorities and focus are on the system services. Next slide. So the Homeless Management Information System, or HMIS, is one of our key investments in this division. It is the data system used by all publicly funded community providers to record information about the services they deliver and the people they serve. Multnomah County, alongside our regional partners at Clackamas and Washington counties, are currently migrating to a new HMIS platform. This effort launched earlier this year in February, and we are on track for phased implementation and testing through next fiscal year. With this investment, we're looking forward to delivering a system that is easier for the end user to navigate, supports better care coordination across providers, and expands real-time access to HMIS data for insights and decision-making. This transition will allow us to expand data collection and continue our commitment to modernization. Next slide. So this slide covers reporting and analytical improvements within this division. The information that is being entered into HMIS is used in a variety of ways. So we use the data to power our by name lists, and as you can see, we're continuing to make improvements there. This data also helps to build better tools, like the contract monitoring tool we launched this year. This tool allows HSD staff and community providers to track contractual goals together. Into next fiscal year, we're going to start a new effort to closely look at our shelter system. We want to better understand and gain insight into how our shelter system is performing around navigating people from shelter to housing. Also, we'll be launching an updated version of the HRS dashboard in the first part of next fiscal year. And then lastly, our department is also committed to in-depth evaluation of our system. It really helps us to get from the what to the why, and those projects are listed above. We can then understand the experiences people are having at more depth and nuance, always with the goal of being able to design more effective programming. Next slide. So I already spoke to the big HMIS move underway, and the quality of the data entered is still a top priority for us. So we have expanded the training library and made them easier to find and access so providers have extra support in getting data into the system correctly. And right now we're focused on three main things. One is more tools for providers. Second is monthly reports and smarter cleanup tracking. And then thirdly, staying responsive on duplicate merges. Next slide. All right. So these last two slides highlight data from fiscal year 25 on who completed coordinated access assessments. And so that's another program within this division. To note, we project that in 27, we're going to assess about 1,800 people. That's closer to our 2025 rate. Some reasons for that is there was a slight budget reduction in staffing associated with coordinated access assessors. Also, in response to the potential impact of our upcoming COC NOFO, we expect that we may need to redirect capacity on our assessor team to support in program closures or potential transfer processes. Next slide. And so this is who is assessed by race and ethnicity. Our fiscal year 25 data shows that we continue to assess almost all communities of color at or above the rates they are experiencing homelessness. However, we do have a shortfall with Asian and Asian American populations. We don't have that backdrop for you. However, if we go back to some previous slides on 72 or such, you can see that percentage rate of folks, of their rate of experiencing homelessness, in total. All right, that's the end of this division.
Can I ask clarifying questions about what we are screening for? Is it just the right housing options, or is it other related issues?
So once the MIST is done and we know sort of that person's situation, are you talking about this after that?
No, that situation, like what is it that we're collecting? Yeah, what are we coordinatingly assessing?
I mean, I can start us by saying it's housing resources and connection to where a person is at. So it's not going to assess everything. It's not a behavioral health assessment. The main goal, if we think about coordinated entry, is to connect folks to housing or housing resources. And so some of what you're doing as an example with the MIST assessment, is if a person just needs 1 or 2 months of eviction prevention as an example. So you're looking at what is that full range of a continuum of support they may need. And so in that process, you have different areas or intervention phases. And so housing problem solving is the new term, which is a term, which is essentially right before maybe somebody who needs that 1 to 2 months versus a longer term. It's identified this person may need a longer term commitment, like PSH as an example. In certain systems, we utilize coordinated access in different ways. And so in the DV system, as an example, they use it through looking for shelter. We have coordinated access for shelter, for rapid rehousing, for PSH. So it's not always just specific to housing if you think about coordinated entry as the process, but I think you're specifically asking us around the MIST and how we use coordinated entry for housing specific programs.
Yeah, I'm just curious because of, we kind of have some very specific possibilities for certain populations around housing, like the Medicaid waiver housing that Department of Human Services is doing. So I'm just wondering how we can figure out who might be eligible for some of the niche, I guess I'll call it, but there are so many different random funding.
Could we use that tool to identify other service eligibility? Is that correct?
Or maybe in that tool, are we like, oh, they are receiving services from ADVSD that might flag, they might be eligible for certain, I just didn't know what it was able to.
So the tool is, MIST stands for Multnomah Services, something screening tool. But it's basically looking at, it's to assess a person's level of vulnerability. It looks at length of time homeless, number of episodes homeless, have they been evicted, are they at risk of eviction, do they have a disability, and then there's some questions around age, do they have a child in the house, what age is that children? So there's a series of questions that is designed to help understand that household's vulnerability, and then that information helps them land yes or no in the priority pool, and then out of the priority pool, the housing match is made. So there's a couple steps there.
If I may, Nathaniel Frigow, I'm Department Director. I'm still learning the systems here, but my understanding is that it would be within the priority pool that determinations of eligibility for programs like you're talking about would be made. And in the build out of the new HMIS system, we can be looking at how we track specific eligibility, both in program intake and potential other questions, so that as folks who are assessed to need permanent supportive housing through the MIST, we can pull HMIS data and other data to be able to determine appropriate matches to specific resources based on eligibility.
That made me have like a billion other questions. So I would love to get an update overall about how coordinated access is operating and what programs are under it for the adult system. Because I'm hearing you guys talk about things like eviction prevention and rapid rehousing, and we had always tried to keep those flexible programs out. Well, that's what the Medicaid is, right? So I just want to understand what it looks like now. That doesn't have to be here today. I am curious, what's the current wait list number on the coordinated access list?
We'd have to follow up with you on that.
Okay.
Yeah.
And part of it is, I know we want to assess folks so that we know what it is, but I think it's also important to know what the wait actually looks like for people. So yeah, follow-up's totally fine. I would also love to have a little more detail on some of the, from slide 80, the in-depth and qualitative evaluations. Again, don't need it now, but wanting to understand a little more detail of what those research questions are that we're asking and how providers are being engaged. I only see one survey that includes shelter, and we have so many other programs that I'm not sure that we're getting participant feedback on. So I'd love to just hear a little bit more about that.
But certainly can follow up. I will say that Pathways Part 2 is on one of those, and that is 100%, well, not 100%, but that is built on working with providers. So Part 2 is a more qualitative analysis of the survey comments from folks who are either still homeless or recently housed from homelessness. So that's really intensively built on folks with lived experience. And we have come before the board about a rapid rehousing evaluation in the past. We can give an update on where we're at with that, but it works directly with providers to help us better understand rapid rehousing. But we can provide more detail to the whole board.
Yeah, great, thank you. You've got program offer 30003. It has some language around contract monitoring. I see that in other program offers. I'm having a hard time understanding how contract management and monitoring is happening in the department, because it seems like there's pieces in a lot of different places. And so I will say, as a former provider, I don't know if that's super clear to folks. It feels like there's a lot of cooks in the kitchen. Maybe there isn't, but it shows up in a lot of places. And so understanding what role does the data research and evaluation team play in contract monitoring, or is it just a typo? And then what roles all the other staff play in contract management and monitoring?
You want to start with the contract monitoring? I'll talk about the data team role.
Yes, and contract managers, I assume, are funded throughout a lot of the program offers, so maybe that's probably why you're seeing that type of phrase there.
Which I get. For program staff, I get. I think I'm trying to understand, what is program staff's role? What is data's role? There was something, I think, in business services that refers to contract management. So I'm wanting to understand what all those different, not each program program staff, but what each of those sorts of roles are when it comes to the contract.
Sure. So we call ourselves a trifecta within HSD, where you have fiscal and business services, data, and then on our program team. The program team side, our goal is the external facing with our providers when it comes to contract administration and management. And so what that means is, we're not internal business services, we'll go internal and kind of help us move some of the contracts through our internal county system. For us, when we talk about contract management, it is supporting our providers in what we're asking them to do and what service delivery they are doing. And so contract management can look different. It's a day-to-day thing, but we also have formal monitoring processes. I can talk through what some of those formal monitoring processes are, but the way I would describe it is you have some informal ones and some more formal ones. Some of the formal ones are your on-site monitorings, are some of our annual assessments that we do each year. It's called a desk assessment. We also look back at previous performance from providers, and then we give them that feedback via a letter, have a discussion there with them. Some providers, community-based providers, we meet with on a monthly basis. Others, it's quarterly. They also engage in our system leadership meetings. So there's a lot of outward facing that the program side does. In relation, or maybe to the data, are you going to talk about the data and the contract monitoring? Okay, so maybe I'll pause for a second.
Yeah, so 30003 is the Data Research and Evaluation Program offer. The reason you heard about contract monitoring is that team over the last year has designed and launched and now supports a monthly contract monitoring dashboard that our staff and the providers can look at what outcomes were we contracted to perform and what is our performance on those outcomes so far based upon our performance in HMIS. So they elevated in the program offer that some of the work they support is the data team, because it's a new thing that we're doing that allows us to have better insight into how folks are performing more quickly. And so that's why you see it in there, is because they launched it and they designed it, and now they are supporting each month the upload of that new HMIS data, making sure it's correct and getting it out to providers on our staff so they can see those outcomes on a monthly basis.
So if I'm a provider, do I have multiple points of contact or one point of contact with the department?
So the data team is supporting the creation of the dashboard. They're not necessarily talking to the provider about it unless the provider has a question about how to use the dashboard, but it's a tool for them to use in their own management. But they may have more than one
you said, and they'll send it out to the provider, so that's why I'm asking the follow-up. So if I'm a provider, do I have a contract manager? I know who that one person is, or are there multiple points of contact that I have?
We are your primary form of contact, and if you're a provider and your data team needs support and technical assistance to navigate HMIS, we're going to connect you then to the data team. One of the things our contract administration plan that centrally, was rolled out this year is it helps us list out, here is who is your team. And so we send that out to the providers. We'll do it again this year of who is on your team of people so that you know. Because the business services side may also have a point of contact if, the provider's fiscal side needs it as well. But the program side will be your primary outward-facing group. And so oftentimes our providers will come directly to us as the main point of contact.
Great, thank you. You'd think I'd be done, but I'm not. In program offer 30006C, Regional Coordination Homeless Management, beginning working capital is listed in there. Is that SHS?
For the record, this is Antoinette Payne, she, her pronouns, Finance Director. Yes, it is.
Thank you. And I would love, and this can come as follow-up, just a little more detail on 30100. A lot of the language in the program description sounds like things that are contracted out, but then it has 7 FTE, and so I'm just trying to understand. It's okay. I know I'm reading from the actual budget book. I don't expect everybody to have it. You can just send it in follow-up, because I know Elkin's writing all this stuff down too. But just would love some follow-up to understand what is the county staff role versus what is contracting role or contractor's role in that program offer. 30100.
So at least I can answer some of that. At least on the program side, it'll be our coordinated access staff.
Gotcha.
More specifically, but I assume there might be others across it. We tend to call this is our division with a lot of little things in it that support that system, and so I assume there's other department FTE.
Okay, yeah, if I can get that in follow-up, that's fine. And how many FTE are for each category? Thank you.
Other questions around this? Okay. Okay, and then I think we have another division. One more, administration and operations.
The most exciting one.
I tried to.
I appreciate that. Those cookies are kicking in. Let's go. For the record, my name is Emily, and I use she and her pronouns. I'm the equity manager at the Home Services Department, and I am going to briefly go over our admin and operations division. As Kanoya just uplifted, where system support, access, and coordination is where we provide the support and coordination for our system of services. Admin and operations is the division where we provide support and coordination for our department itself. And we can move to the next slide, please. So our challenge here is because we prioritize the HRAP and the LIP in making budget and program decisions, we had to make sure that we were making commensurate decisions aligned with our values to the admin and operations division, as those community plans don't contemplate admin and operations. Within contraction, we are prioritizing our ability to provide what you could call the behind-the-scenes work that supports our department. This is where we're able to operationalize our WESP initiatives and support staff, communicate with our partners in the community, as well as support our equity goals and accountability in contracting. Next slide, please. As Kanoy pointed out earlier, prioritizing core services meant taking commensurate cuts across all divisions. So despite a relatively small cut to the operations budget of this division, applying an equity lens in our approach meant we made FTE cuts across all divisions. And we can move to the next slide. So this slide depicts the work in this division: fiscal accountability, strategic and equity-focused leadership, support of staff hiring, onboarding, retention, and development, and managing communications to keep the community informed. And then within each of these bodies of work, we continue to prioritize the application of our equity values and strategies. Next slide, please. Oops, I lost my place here. So because so much of this division supports our workforce equity work, it was important to us to align our outcomes and KPIs for this division with that work. This includes measuring staff's experience of belonging in alignment with countywide values and the workforce equity strategic plan. This will be measured in stay and exit interviews, as well as in the department level results of the countywide survey, and it supports our accountability to the outcomes of our workforce equity goals. Next slide, please. So our intent is always to support people choosing to stay in our department because it is a good place to work, and wherever possible disaggregating to make sure that we're not having a disparate impact. One thing that's important to note is that we have had no involuntary separations outside of the budget process, which in part speaks to the strong partnership between HR and equity teams in our department to ensure that we're not inequitably applying disciplinary practices. And we can move to the next slide. As equity is a core component to all the work of our department, it's important for us to also understand staff's experience of our equity implementation so that we can ensure our efforts are having the intended impact and identify opportunities for improvement. So this is measured through staff surveys. Employees report whether the department actively prioritizes equity and inclusion. The survey includes a statement: I am satisfied with the amount that equity and inclusion are prioritized and acted upon, and staff are asked to indicate how they feel on a spectrum from strongly disagree to strongly agree. As you can see on the slide, in FY26, 50% of surveyed staff agreed or strongly agreed with this statement, and for FY27, it is our goal that at least 75% of surveyed staff will agree or strongly agree. We also solicit staff feedback on our equity work through many other feedback pathways, and we know that it is a priority for our staff that they can see our equity values in action. And I'm going to pass it back to Antoinette for the next slide. Questions?
The next section is additional considerations. So that's the end of this division, if you have division questions.
All right, any questions around administration and operations?
Yes, I do. I'm trying, so I see a 5 FTE reduction, I think a 1.5% funding reduction. Overall, Homeless Services is experiencing nearly a 30% overall. Why? Not necessarily do I feel like you need to achieve that with FTE, but why is this area not seeing a higher percentage reduction?
I want to clarify that we took the budget is 23%, and we, across the whole department, cut 16 FTE, which was about a 14% decrease. So it's not concentrated in the administrative and operations division. We really, the first sort of, you've heard them say the reductions have to be commensurate across our divisions. We did, first cut was where are we cutting services, and if we're significantly reducing services, it would then make sense to reduce the staff who support those services. So, for example, we made some reductions in our shelter support programming is one of the places that we took reductions. The admin and operations also took a commensurate reduction because we know we have to be cutting our administration at the same time that we cut the program support. So that is, so the administrative support is, if you look at the FTE across, it's a far more like parallel reduction.
Y'all are looking at me. I don't have any questions.
I'm not hearing any, so why don't we move on to the additional considerations, and then if folks have more, we can.
Okay. Let's pull up the slide deck. So I'm going to provide an update regarding our funding from the state. If you can go to the next slide. Next one. So in the 2025 Oregon legislative session, they passed House Bill 3644, which requires a statewide shelter program in Oregon. Oregon Housing Community Service, OHCS, will serve as a minister of 36 regions who will be distributing these funds for this House bill. The primary goal is to administer shelter service for assigned regions with an emphasis on trauma-informed and culturally responsive practices aimed at reducing unsheltered homelessness and transitioning individuals into stable housing. Multnomah County is one of the regional coordinators for the statewide shelter program. Just as a reminder, during the state rebalance last fall, we used $3 million of our year 2 funding. This leaves $3 million less for shelter operations. On a positive note, for fiscal year 2027, funding from the state has increased as we have been granting an additional $2.7 million for shelter. These additional funds are to continue the shelter program that prioritizes state-funded shelters, including the city's 24/7 shelters that previously received state funding. You will see this $2.7 million included in the FY27 budget amendment. So we'll be coming back to bring an amendment to increase the Fed and state funds by $2.7 million. So for FY27, we have about $17.9 million in the approved budget, but if you include the 2.7, we will have in totality $21 million that we were receiving overall from the state. If you can go to the next slide, please. This slide kind of displays the 3 bienniums of state funding levels, and you can see year over year the funding has fluctuated over time. Next slide. And then lastly, we have some additional policy consideration. Metro leadership continues to explore changes to the measure. We are entering year 6 of the measure. Next hurdle is renewing it. HUD, Multnomah County Homeless Services Providers, partners receive significant funding from the Department of Housing and Urban Development, which remains uncertain. We've seen some impact in FY27 around the emergency vouchers, but the biggest impact will come in FY28, and we have started planning for that. And then lastly, DEI, federal required changes will impact our ability to fund focused programs and service designed to address disparities in our homelessness population with federal dollars. Local funding will be required to continue to fund programs aligned with our core values of equity and inclusion. And that is all we have. Any questions?
Just to clarify, for the additional $2.7 million for year 2 funding from the state, what are the, what are the sideboards around use of those dollars?
It's for shelter operations.
In general?
In general, yeah.
Okay, great.
Fine.
Any questions on the additional considerations? I know all of us on the board are really interested in some of the conversations that are happening obviously with what's happening at the federal level, but definitely the conversation with Metro on SHS changes, and so we're staying actively involved in that.
I have a question related to SHS proportionality. If you look at the 3 counties in the distribution of SHS, how much money per person experiencing homelessness does Multnomah County get versus Clackamas and Washington? And I know there's a long history of why that is. I'm not trying to dig that up, but I am trying to I find it very hard when people compare counties, and so I'm curious where that is at right now.
So the short answer is a lot less, and we have done some quick arithmetic on that, so we can follow up with that arithmetic. I do want to go back one thing to the 2.7 from the state. We do understand from the state that they would like that additional funding to continue to support city programs, to continue their historical support of city alternative 24/7 shelter programs. So I just want to, Antoinette said that, but I just wanted to make that clear that it is for shelter operations specifically for city sites.
Like legally binding? Or is that a suggestion? Because I thought we had an IGA where we were getting $31 million from the city, and that also seems to be optional. So I'm curious about how legally binding is that? Is it IGA level legally binding?
You're getting thumbs up from the back of the room.
So I have a follow-up question. This is like an overarching question, and I don't need it right now, but I was just looking at the span of controls. But again, the FTE from the department seems like relatively smaller compared to the contracted staff. And I'm wondering if you can supply the number of contracted staff.
We are close to having that for you to look at both the number of contracted staff and how the reductions that we conservatively estimate they would take compared to the FTE reductions that we made. So in our follow-up to you all, we will have both those pieces of information.
Yeah, it would be good to get the denominator and then what the other piece. And I'm curious, in our contracts, just because so much of the county work is in contracts, do we specify at all span of control? So the same discipline that we're asking county departments to engage in terms of a span of control, is that?
No, we do not specify that for our contractors, no.
So like the supervisory or managerial roles, that's just for them to decide?
We have rules around what we will fund in terms of those types of roles, but we do not specify what that would look like for them.
And then this is a question I had asked last year. Do all of the contracts that are going to be rolled forward to next year, continued with providers, will they have performance goals in the contracts?
Yeah, so our contracts, so that contract monitoring tool is one of the ways that we're continuing to emphasize that. So our contracts are, we're paying you to do this thing, and here's how we'll know that you're doing that thing. So it's 50 housing placements or engaging with 100 people via outreach. And so that is in the contract. They are quarterly sort of reporting requirements, and now it's a monthly, we can see in HMIS how they're doing in relation to those performance targets. So yes, our contracts have performance goals associated with them.
Some curious, in a resource-constrained environment, how we'll use that as sort of as a tool to be contracting with the highest performing providers. Again, I felt like the shelter report gave us some data, but it seemed like some of the decisions were made more based on like the facility or the cost of the the condition of the facility or the cost of the rent. And I'm just curious, going forward, how we use this tool of like.
So I'm going to talk about that in a couple different ways, and then my colleagues can join in if I miss something. So in terms of budget decision-making, as we spoke a little about, Emily spoke a little bit about our program offer evaluation tool. So when we were making our reduction decisions this year, we created a program-level tool that looked at performance of our programs in a variety of ways. It did look at sort of design to reduce disparities and performance on that, but it also looked at what are your outcomes and are you performing as outcomes. So that was a part of our consideration as we made our reduction decisions this year. And then on an ongoing basis, as we're doing that contract monitoring throughout the year, we are knowing if people are meeting their outcomes and their outputs or not. And that becomes a performance conversation throughout the year if people are consistently not meeting their outcomes and they can't articulate a justification that works for us, right? So that's an ongoing performance management conversation that is primarily led by the contract managers that Kanoy was talking about earlier with Commissioner Singleton.
And one of the other pieces this year is ensuring that we had standardized performance measures across all of the contracts, because you don't want to be comparing apples to oranges. And so that was a big push in fiscal year 26 to ensure all shelter contracts, your performance measures look alike, right? And so on and so forth. And so that'll help us even further be able to do that.
Yeah.
I have a question about the assistance we're providing to our various providers, particularly in training and other areas. I think there is some reductions. I don't remember what slide that was on, but I'm just asking about that because I have some nervousness. I highly support the work we're looking at around trying to get some consistency and standards on what is case management. I'm very interested in outreach. I was a little concerned by the city's response to how are we coordinating outreach, which seemed like a massive lack of coordination, frankly. I'm like, so depending on what worker happens to talk to me is going to be a defining factor of where I end up is concerning. I know we don't control their budget, but I'm wondering, as we roll some of this out and as we try to get some greater consistency and performance improvement, what challenges might we have with our ability to get that out to providers?
So I have a few different answers to your question, and then colleagues might have more. So we didn't, to my knowledge, I don't think we made any cuts to the training that we're providing or coordinating for our providers. So we have a training position on the equity team that does equity-focused training coordination, and coordination meaning developing and delivering trainings, but also coordinating and connecting providers to trainings that exist in the community, connecting providers to cross-training opportunities with each other, those kinds of things. We also do some training. There's a trainer that provides training around DV services for providers that aren't DV specialists to be able to understand how to support people experiencing DV in their services. We also participate in a regional table with Metro that's working to develop a training curriculum and some of those standard service delivery aspects that you mentioned. So we participate in that, and our training staff participates in that around best practices and access and design. And then I had one more answer. Yep, we also, there was a cut to assertive engagement. That might be what you're thinking of. That was in partnership with DCHS. That initiative originated in DCHS and has always lived there. We expanded when we had the opportunity to with SHS and had some DCHS support, assertive engagement support in our department, and that it has gone back into DCHS and now lives back in DCHS again. But there was one other thing I wanted to ask about. Oh, and we are, I think we mentioned it yesterday, but we're in the process of developing an outreach manual for our funded outreach providers. So we are providing some guidance and best practices to our contracted providers around outreach. And again, we don't have contracts with the city, but for our outreach, we're developing a manual.
And Jillian mentioned this, I think, during their presentation, but they are working on a countywide case management like review evaluation, and we are active participants in that. And by we, I mean Kanoy as our point person to help us participate in that and work with our providers to, yes, to kind of gather that information for that larger understanding of case management.
You guys are awesome. It's a lot of work. I appreciate it. I appreciate 2 days of this plus the infinite amount of work that went into it before. So just want to appreciate y'all.
Truly infinite. Thank you all very much. I will say the earring game is strong on this team right here. And
It is. I was like, oh, I want those.
yeah. So, yeah. So, thank you all, and then, yeah, so thank you. I think that's all. I don't know that we're going to need to bring you back for any follow-ups, but I know that there were lots of questions that were asked, and so we'll let you know if that's possible, but I'd appreciate to get those answers in writing so that those can be distributed. And I know Kristen and her team were jotting down, as I'm sure many people were in this room more. So thank you all very much. So that is our agenda for this afternoon. So before we close, are there any budget amendments or notes that anyone would like to bring forward? Yes. All right. No, you guys can.
You guys can go.
You are just, you guys.
Thank you. I just have a budget amendment here to build off of the success from the OSU Extension Program and expanding that and supporting some of the workforce development work and building out that program here within the county and region.
All right.
Yes.
Thank you.
And we'll provide an offset after the forecast on the 20th.
Okay, great, thank you. Thanks, anyone else for this afternoon? Okay, that concludes today's budget work session. Our next meeting is going to be our regular board meeting scheduled for tomorrow, Thursday, May 7th, not until 9:30 a.m. Yes, so there being no further business, we are adjourned.